Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session I'll be discussing a very important topic in the neurology, that is the meningitis. So what exactly is the definition of meningitis? Meningitis, it is the clinical scenario where there is the inflammation of the meninges. And these meninges, they include pia mater, then subarachnoid, and then we have dura mater. So the inflammation of the meninges will be your meningitis. And you see this important question here. Bacterial meningitis, it is an acute purulent infection within the subarachnoid space, subdural space, extradural space, all of the above. Let me tell you, bacterial meningitis, it is an acute purulent, or any meningitis, it is an acute purulent infection within the subarachnoid space. Right, it is within the subarachnoid space. Okay, so please remember, this is a very important point. Now, so bacterial meningitis, it is acute purulent infection within the subarachnoid space. Now the important features, right, this bacterial meningitis or meningitis, it is associated with a CNS inflammatory reaction. Right, it is associated with CNS inflammatory reaction that may result in decreased consciousness of the individual. Right, that will result in decreased consciousness of the individual. There can be development of the seizures, and there can be raised intracranial pressure and the development of stroke. Right, so these are the important features of the meningitis. So we have one more terminology called as meningoencephalitis. Right, meningoencephalitis. So what is meningoencephalitis? It is the inflammation of meninges and as well as the encephalon, that is brain parenchyma. So meningoencephalitis means inflammation of meninges, that is meningitis, plus inflammation of the brain parenchyma. Okay, so that is what is called as the meningoencephalitis, right? And in case of meningoencephalitis, these manifestations are very common. That is, when there is involvement of the encephalon, that is brain parenchyma, that is the point when the individual will have decreased consciousness, seizures, raised intracranial pressure, and as well as the development of stroke. Whereas in meningitis, the individual will have mainly the clinical presentation in the form of the headache, fever, and as well as vomiting. So these will be the manifestations in case of only meningitis. Whereas in meningoencephalitis, you will have this decreased consciousness, seizures, raised intracranial pressure, and as well as stroke. Now, you see another question. The organisms most often responsible for community acquired bacterial meningitis are Streptococcus pneumonia, Neisseria meningitidis, group B Streptococci, and then Listeria monocytogenes. So the most common organism which is responsible for community acquired bacterial meningitis, it will be the Streptococcus pneumoniae. Right, it will be Streptococcus pneumoniae. Now let me tell you the organisms most often responsible for community acquired bacterial meningitis. So these organisms, they include number 1, Streptococcus pneumoniae, that will contribute to nearly around 50%. Then Neisseria meningitidis, right, followed by that group B Streptococci, right? And then followed by that Listeria monocytogenes. Okay, so these are the organisms which are responsible for the development of bacterial meningitis. Okay, now after having discussed about the organisms, now let me tell you which of the organism that will cause post meningitis deafness. The options are Listeria monocytogenes, pneumococcus, Haemophilus influenzae, Staphylococcus. The answer is the Haemophilus influenzae. Haemophilus influenzae, that will be the organism which will cause the post meningitis deafness. Now, let me tell you the organisms causing meningitis according to the age of the individual. You take in case of the neonates, right? If you take in case of the neonates, the most common organism which will be causing meningitis will be group B Streptococci. Right, group B Streptococci. And particularly if you take in India, the most common organism which will cause meningitis will be Klebsiella. And followed by that Escherichia coli, right? And the other organism which will cause meningitis in neonates will be Listeria monocytogenes. Okay, so these are the set of organisms which will cause meningitis in neonates. Whereas you take in case of children, in children the organisms causing meningitis will be pneumococcus, right? Then followed by that Haemophilus influenza. These are the organisms which will cause meningitis in children. Whereas you take in adults also the most common organism will be pneumococcus. Right, it will be pneumococcus, right? And in winter, okay, particularly winter seasons, the most common organism which will be causing meningitis will be Neisseria meningitidis. Right, Neisseria meningitidis. So these are the organisms which will be causing meningitis according to the age of the individual. In neonates, it is group B Streptococcus. In children, it is the pneumococcus. And particularly in India, in case of neonates, it is Klebsiella. And in adults, the most common organism will be the pneumococcus. Now, followed by that, you see this very important question. Gram-negative bacilli cause meningitis in individuals with all of the following conditions except. The options are the diabetes, cirrhosis of liver, alcoholism, congestive heart failure. So, the question is, which particular group of individuals will develop the meningitis by the gram-negative bacilli, right? But the question asked is except. Let me tell you, the group of individuals, they develop meningitis by the gram-negative bacilli, okay? So, these particular clinical conditions include, number one, diabetes mellitus. So, diabetics, they are more prone for meningitis by gram-negative bacilli. Then, cirrhosis of liver. Next, alcoholism, and in those with chronic urinary tract infection. Okay, so in these clinical scenarios, they are more prone for development of meningitis caused by the gram-negative bacilli. So if you go back to the question now, gram-negative bacilli cause meningitis in individuals with all of the following conditions except, what will be the answer? That is the congestive heart failure, right? Now, at the same time, you need to know what are those gram-negative bacilli. So, if you take the gram-negative bacilli, the organisms include the Escherichia coli, then followed by that Salmonella, then we have Shigella, then we have other Enterobacteriaceae, next we have Pseudomonas, and lastly we have Moraxella. Right? So these are the organisms which will cause the meningitis, which are gram-negative bacilli causing meningitis. Now, out of which you take this Neisseria meningitidis, right? Some important points regarding the Neisseria meningitidis. So, what did I tell you? The Neisseria meningitidis that will cause meningitis, particularly in case of adults. Right, in adults, most commonly in winter season, the meningitis is caused by your Neisseria meningitidis. Now, let me tell you how is this particular Neisseria meningitis is being spread, right, and what will be the manifestation and how do you treat. So, this Neisseria meningitidis, it is being spread by the droplet infection. Right, it is being spread by the droplet infection. And the endocrine disorder which is associated with the development of Neisseria meningitidis is acute adrenal insufficiency. Right, acute adrenal insufficiency. And this acute adrenal insufficiency, it is also called as Waterhouse-Friderichsen syndrome. Right, it is called as Waterhouse-Friderichsen syndrome. And if you take this Neisseria meningitidis, how can a doctor get protected himself by the droplet infection? That is by N95 mask, he can get protected to himself. And what will be the chemoprophylaxis in the healthcare individual? The chemoprophylaxis is mainly by the third generation cephalosporins. Right, that is by third generation cephalosporins. And if a family member, if he is in contact with the patient with Neisseria meningitidis infection, what does a family contact have to take as a prophylaxis? That family contact has to take ciprofloxacin. Whereas in pregnancy, if there is infection by Neisseria meningitidis, then what is the drug that you have to give? That is ceftriaxone. Okay, so that is the treatment of the Neisseria meningitidis. And let me tell you, in these patients with the Neisseria meningitis, there is appearance of petechiae around the ankle. Right, the presence of petechiae around the ankle, it is a characteristic feature of the Neisseria meningitidis. Now, after having discussed about the organisms causing meningitis, now let me tell you what exactly is the pathophysiology of the meningitis. Okay, so the pathophysiology of the meningitis is that the immediate effect of bacteria or any other microorganism in the subarachnoid space is to cause the inflammatory reaction, right? So you take bacteria or you take any particular microorganism. What is its first important thing that to induce meningitis? In the subarachnoid space, it has to induce the inflammatory reaction. Okay, so right, inflammatory reaction in the subarachnoid space. So the immediate effect of the bacteria or any other microorganism in the subarachnoid space is to cause the inflammatory reaction, right? So not only in the subarachnoid space, this bacteria will also try to cause the inflammatory reaction in the pia mater and as well as the arachnoid matter. Right, as well as the arachnoid matter, and apart from that, even within the cerebrospinal fluid. That is what is the bacteria or other microorganism do. Now, since the subarachnoid space is continuous around the brain and spinal cord and optic nerve, the subarachnoid space is present around the brain, it is present around the spinal cord, is also present around the optic nerve. So, an infective agent gaining entry to any one part of the space may spread rapidly to all of it. Okay. So, since the subarachnoid space, it is present around the brain, right? It is present around the spinal cord and it is present around the optic nerve. And it is present around the optic nerve. So, an infective agent gaining entry, right? An infective agent gaining entry into one particular space may spread rapidly to all of it. Thus, right? Thus, meningitis it is always cerebrospinal. Right? Meningitis, it is always cerebrospinal. Okay. Next, the first reaction to bacteria or their toxins is hyperemia. What these bacteria have to do in order to induce the inflammatory reaction? This bacteria first reaction is to induce, the first reaction to bacteria or their toxins is hyperemia of meningeal vessels. Right, there will be hyperemia of meningeal vessels, that means meningeal venules and as well as meningeal capillaries. And because of hyperemia of meningeal vessels, there is increased permeability of these vessels. Right, there will be increased permeability of these vessels. Now, once there is increased permeability, what will be the subsequent event? Once there is increased permeability of these vessels, this leads to exudation of purulent fluid in the subarachnoid space. Okay, so this leads to exudation of the purulent fluid exudation of the purulent fluid into the subarachnoid space. Now, for suppose if the infection is controlled at an early stage, the exudated fluid will disappear. Right? For example, if the infection if it is controlled at this particular stage, then the exudated fluid will disappear. Right, the exudated fluid will disappear. But for suppose, if the infection becomes chronic, the purulent fluid undergoes organization and fibrosis. Right, for suppose, if the infection becomes chronic, right, then in such case, the purulent fluid undergoes organization and fibrosis. Right, the purulent fluid undergoes organization and fibrosis. Okay. Now, suppose, right, suppose if the infection becomes chronic, right, suppose if the infection becomes chronic, there is fibrous overgrowth of meninges. Right, so if the infection becomes chronic, there will be right? There will be fibrous overgrowth of meninges resulting in thickened, cloudy or opaque subarachnoid space, right? There will be fibrous overgrowth of meninges causing cloudy, thickened and opaque subarachnoid space, okay? And often the adhesions between the pia and as well as the subarachnoid matter will be there. So you have, see, the pia matter is innermost matter, middle is subarachnoid, outermost is the dura matter, and in between the pia matter and as well as subarachnoid matter you have the formation of the adhesions, right? And often adhesions are being formed between the pia and as well as the arachnoid, right? So that is what is the basic pathophysiology of meningitis. And the production of exudative fluid is responsible for hydrocephalus in meningitis, right? The production of the production of the exudative fluid that is responsible for hydrocephalus in meningitis, right? And okay, that means when the exudative fluid is accumulated within the subarachnoid space and when the meninges are being fibrosed, then the cerebrospinal fluid, it cannot be absorbed across the subarachnoid space. It is actually the lymphatics which are present in the subarachnoid layer of the meninges will absorb the CSF. But here, once there is fibrosis of the meninges, the subarachnoid space or subarachnoid layer will not absorb the CSF. Once the subarachnoid layer does not absorb the CSF, what will happen? That will make the individual to land up in the development of meningitis. And in acute cases, large amount of fibrinopurulent fluid may collect somewhere in the pathway of the CSF and block the flow of the CSF, okay? So in acute cases, so the hydrocephalus can be there in acute cases and as well as even in chronic cases also. So in acute cases, right, in acute cases, how there is development of the hydrocephalus? In acute cases, large amount of the fibrinopurulent fluid large amount of fibrinopurulent fluid that gets accumulated in the pathway of the CSF. Right, that gets accumulated in the pathway of the CSF and will block the flow of the CSF. Right, will block the flow of the CSF. And that will result in development of hydrocephalus. Okay, so that is in acute cases, right? So hydrocephalus may occur in acute cases, but it is more common in the chronic cases, right? The hydrocephalus, it is more common in the chronic cases. In chronic cases, what did I tell you? The exudative fluid undergoes fibrosis. Right, the exudative fluid will undergo fibrosis, and once the exudative fluid undergoes fibrosis, that will produce subarachnoid space adhesions, and once there is subarachnoid space adhesions, that will result in the block in the flow of the CSF, resulting in the development of hydrocephalus. So the pathophysiology of meningitis ultimately is that there will be the long-term complication is the hydrocephalus. So initially what will happen? Either you take bacteria or any microorganisms, they need to induce the inflammatory reaction within the subarachnoid space and as well as the vessels of the subarachnoid space. So once there is the inflammation of subarachnoid space or vessels of the subarachnoid space, that is subarachnoid space venules or meningeal venules, there will be hyperemia of these particular vessels, hyperemia of the capillaries. So once there is hyperemia, that will cause exudation of the purulent fluid into the subarachnoid space. And if the infection is controlled at an early stage, the exudative fluid may disappear. But if the infection becomes chronic, the purulent fluid undergoes organization and as well as fibrosis. So even in acute cases of meningitis also, there can be development of hydrocephalus. How? That is, when the fibrinopurulent fluid, if it is collected somewhere in the pathway of the CSF and block the flow of the CSF, that will lead to the development of hydrocephalus. And in chronic cases, there will be fibrosis of the meninges. So because of the fibrosis of this particular meninges, the CSF is not absorbed across the meninges, that is across the subarachnoid layer, and that will produce the development of the hydrocephalus. Okay, so that is about the pathophysiology of the meningitis. Now you see, your subarachnoid space, it is present around the brain, and subarachnoid space is also present around the spinal cord. So you have the inflammation around the brain and as well as inflammation around the spinal cord, and you also have the inflammation around the cranial nerves. So in these individuals, the cranial nerve and as well as spinal nerve involvement are they are more common in case of the chronic meningitis. Now, what will be the clinical manifestations in meningitis? So basically what we have discussed in pathophysiology, how the purulent fluid enters into the subarachnoid space and how there will be development of hydrocephalus. These two important things we have discussed in the pathophysiology. Now, what is the triad in case of meningitis? If you take the clinical features, these individuals, they have very high grade fever. Right, they have the development of high grade fever, then headache, then followed by that nuchal rigidity. Right, followed by that nuchal rigidity. So this is a triad that you will see in patients with the meningitis: high grade fever, headache, and as well as the nuchal rigidity. Now apart from that, why there will be nuchal rigidity? Let me explain you with the image. See, in these individuals, there is inflammation or accumulation of the purulent fluid in the subarachnoid space. And this subarachnoid space, it is continuous with the spinal cord as well. So now this area or this part of meninges, if you see, they are thick and as well as fibrosed, right? Or there is inflammatory reaction within this particular area of the meninges. It is all over, even at the continuation of the brain with the spinal cord. At that point also, you have the inflammation of the meninges. So in this individual, if you try to flex the head, what is that you are trying to do? Whenever you are trying to flex the head, you are trying to do the movement of the meninges also, but meninges, they are inflamed here. So the inflamed meninges, they will not allow you to do a proper flexion of the head, and that will result in what is called nuchal rigidity. Right, that will result in what is called nuchal rigidity. Okay, now, and why there is headache? Because of the inflammation of meninges, and fever because it's an infection. That is the reason why they'll have high grade fever. Now apart from that, so because of inflammation of the meninges, there is also raised intracranial pressure. So because of raised intracranial pressure, right, because of raised intracranial pressure, these patients, they have the development of projectile vomiting. Right, they have the development of projectile vomiting because of raised intracranial pressure. Okay, now the next important point here that you have to understand is that, see, one, definitely they have this projectile vomiting, and because of raised intracranial pressure, there is also the inflammation of the optic disc. And because of the inflammation of the optic disc, there will be also papilledema, right? So papilledema is what? That is due to inflammation of the optic disc. And you see the pupil you will have a dilated pupil, right? The pupil what you will have is a dilated pupil. Now, why do you think that these individuals have the dilated pupil? That is due to compression of the third nerve. Right, so due to compression of the third nerve, these individuals will have the dilated pupil. Okay, and the next important point that you have to know is that because of raised intracranial pressure, there can be sixth nerve palsy as well. Right, there can be sixth nerve palsy as well. So why there will be sixth nerve palsy? Because the sixth nerve, it has longest intracranial course. And because of raised intracranial pressure, it can get compressed at any point within the intracranial space, and there can be sixth nerve palsy. And that will give rise to what is called as a false localizing sign. Right, that will give rise to what is called a false localizing sign. So why am I using the word false localizing sign? Actually, the sixth nerve nucleus, it is present within the pons. So if there is damage to the pons, then the sixth nerve palsy will be there. But if you are finding the features of sixth nerve palsy in the individual because of raised intracranial pressure, you may think that the site of lesion is within the pons, but it is not actually. That is the reason why I am using the word as false localizing sign. Okay, so these will be the features because of the raised intracranial pressure. Right, that is projectile vomiting. What do you mean by the word projectile vomiting? Without having a prior nausea, if the individual has vomiting, that is called projectile vomiting. And the other features of raised intracranial pressure will be papilledema, dilated pupil, that is due to compression of the third nerve, and there can be even sixth nerve palsy as well. Okay, next. And the other important points is that if you take the vision in these individuals, they have photophobia. Right, these individuals, they'll have photophobia. So these are the features that you will have in patients with the meningitis. And you know, as the severity of the meningitis progresses, right, as the severity of the meningitis progresses, there will be decorticate posturing as well. Right, there will be decorticate posturing as well. Okay, that is about the clinical features that you will have in patients with the meningitis. Nuchal rigidity, this we also call it as neck rigidity, will be present in patients with the meningitis. Next, and the other important points that you have to remember that in patients with meningitis, you have these two important signs, that is Kernig sign and as well as the Brudzinski sign. Now, what do you understand by this word, the Kernig sign? Kernig sign is that you have to place the individual in right, you have to make the individual to lie in supine position. Then you need to do the passive flexion, right, you need to do the passive flexion of the hip and as well as the knee. Right, so both hip and knee, keep it in a flexed position, and from the flexed position, right, so this will be the flexed position. From the flexed position of the knee, you slowly try to do the extension of the knee, right, passive extension of the knee. Okay, and when you are doing the passive extension of the knee, what is that you will have? You will have severe tenderness in the back of the spine, right, you will have severe pain in the back. That is what is your Kernig sign. So Kernig sign, the patient is made to lie in the supine position with hip flexed at 90 degrees, and whenever you are trying to do the knee extension from the flexed position, knee cannot be fully extended. Right, cannot be fully extended. That is what is your Kernig sign. Okay, and you also have to anticipate what is the reason. See, whenever you are trying to do complete extension of the knee, right, whenever you want to do the complete extension of the knee, let me tell you what will happen. Whenever you are trying to do the complete extension of the knee, you are trying to pull the sciatic nerve. Actually, what is a nerve in the posterior compartment? The nerve that you have in the posterior compartment, it is the sciatic nerve. So what is that you are trying to do? You are trying to pull the sciatic nerve, right? And when you are trying to pull the sciatic nerve, it is indirectly you are pulling the roots of the sciatic nerve, which is originating from the lumbar and as well as the sacral spine. And indirectly you are applying the pressure over the subarachnoid space, meninges in the spinal cord. So that is the reason why. And here it is inflamed meninges. So the individual will not allow you to do a complete extension of the knee. And then we have Brudzinski's neck sign. Almost the concept is same. In Brudzinski's neck sign also, whenever you try to do the passive flexion of the neck, automatically there will be flexion of the knees. Right, automatically there will be flexion of the knees. That is what is called as the Brudzinski's neck sign. So passive flexion of the neck causes the flexion of both hip, right, flexion of both hip and as well as the knee. That is what is called as the Brudzinski's neck sign. Right, now after having discussed about these two important signs, now let me discuss what exactly and how exactly you need to do workup of these patients with the meningitis. So you see this question, which of the following is the correct sequence to be allowed in suspected bacterial meningitis? First option, you need to draw the blood culture sample, the empirical antibiotic, neuroimaging followed by lumbar puncture. Second option, empirical antibiotics, neuroimaging, blood culture sample followed by lumbar puncture. Third, lumbar puncture, empirical antibiotics and CSF culture. Fourth, empirical antibiotic, mannitol, lumbar puncture followed by neuroimaging. Always what you have to do is, first you need to draw the blood culture sample. Then you give antibiotics, right? Then you do a neuroimaging. Then followed by that you have to do lumbar puncture. So this is the correct sequence to be followed up in the workup of a patient with the bacterial meningitis. Now why you have to follow this particular sequence, I'll tell you. So what is the first thing? Collect the blood culture. And then followed by that you give the antibiotic, that too an empirical antibiotic, because we don't know what exactly is the organism growing. So you should not give antibiotic before drawing the sample for the blood culture, right? You should not give antibiotic before drawing the sample for blood culture. See, because in such case, like what happens is you are like killing the organism by giving the antibiotic. And after that, if you take the blood culture sample, it will be of no use. You may get the culture negative also. And then followed by that, you need to perform the neuroimaging. Right, followed by that you need to perform the neuroimaging in case of findings of raised intracranial pressure. Okay, the purpose, the neuroimaging, it is done by either CT or the MRI. So whenever you do a CT or MRI, you will be able to make out the features of raised intracranial pressure. And once the features of raised intracranial pressures are absent, right, in such case you can do a diagnostic lumbar puncture. Right, in such case you need to do a diagnostic lumbar puncture. Okay, so that is the sequence that you have to follow up in the workup of a patient with the meningitis. Now you see this another question. What is the site of lumbar puncture that you will do? That is in between L1, L2, L2, L3, L3, L4, L4, L5. Let me tell you, the site at which the lumbar puncture has to be done, it is in between L3 and as well as L4. Because if you take the spinal cord, it will terminate between L1 and L2. But whereas in children, it will terminate in between L2 and as well as L3. So better to do lumbar puncture in between L3 and as well as L4. Okay, so that is where is the site where you need to do the lumbar puncture. And what are the needles that you will do, that you will use for the lumbar puncture? The needles what we use is Quincke's needle and the Sprott's needle. Okay, so this is your Quincke's needle and this is your Sprott's needle. So these are the needles that are being used for doing the lumbar puncture. Next, followed by that, you see this question. All are the contraindications for lumbar puncture except bleeding manifestations, local site infection, spine deformity, syphilis infection. Let me tell you the contraindications. Right, let me discuss the contraindications for lumbar puncture. See, whenever there is raised intracranial tension, it's an absolute contraindication for doing the lumbar puncture. Why? Because when there is raised intracranial tension and if you do a lumbar puncture, there is chance of transtentorial herniation. Right, there is chance of development of transtentorial herniation. Then followed by that, these individuals, if there is bleeding manifestations, even then you should not do the lumbar puncture. Next, followed by that, if there is any local site infection, that is also the contraindication for the lumbar puncture. And if there is any spine deformities like kyphoscoliosis, even then you should not do the lumbar puncture. And individuals suffering with polio, you should not do lumbar puncture. So these are the contraindications for the lumbar puncture. Next, so you see this question now. All are the contraindications for lumbar puncture except bleeding manifestations, local site infection, spine deformity. These are all the absolute contraindications. But if there is syphilis infection, then in syphilis infection, you should not do the lumbar puncture. Right, you should not do lumbar puncture. Okay, now whenever you are doing the lumbar puncture, what are the layers through which the needle is being passed? Right, what are the layers through which the needle is being passed? Okay, so the needle, it has to first pierce the skin. Then followed by that, the next important tissue which will be pierced by the needle is, you have the subcutaneous tissue. And beneath that particular subcutaneous tissue, we have the supraspinous ligament. Right, supraspinous ligament. And after the supraspinous ligament, we have the interspinous ligament. Right, we have the interspinous ligament. Okay, so this will be the interspinous ligament. And after that, there will be, you will be piercing this layer, that is ligamentum flavum. You see this? This is your ligamentum flavum. Then followed by that, you will pierce the dura mater, and wherein you will enter into the subarachnoid space. Right? That is, you will enter into the area of CSF. So these are the layers through which the needle has to be passed. Because you have to remember this sequence also, because sometimes they will ask you a question altering these particular layers. What is the sequence through which the needle has to be passed? So they can give you a multiple choice question on this. And whenever you are taking out the CSF fluid for diagnostic purpose, what is the maximum CSF that has to be removed? Maximum CSF that has to be removed is up to 20 to 30 ml. Right, 20 to 30 ml of the CSF has to be removed. And you know, like, what is the rate of production of the CSF in an individual? That will be around 20 ml per hour. Right, that will be around 20 ml per hour. And what is the total amount of the CSF that we have in the subarachnoid space? That is nearly around 150 ml. Right, that is nearly around 150 ml. And these patients will have post-lumbar puncture headache. That is the reason why these patients, they have to be advised bed rest. Right, these patients, they have to be advised bed rest. And that particular bed rest should be there for nearly around 6 to 8 hours. And for suppose, now what will be the characteristic feature of the lumbar puncture headache? Right, the characteristic feature of lumbar puncture headache is that, for suppose, if the headache is increasing, right, if the headache is increasing on straining, then it is considered to be a post-lumbar puncture headache. Right, if the headache is increasing on straining, then it is considered to be a post-lumbar puncture headache. Now, what will be the treatment that you will give for this post-lumbar puncture headache? Right, the drug of choice will be intravenous caffeine. Right, that is intravenous caffeine. And the other drugs that can be given is codeine. Right, so intravenous caffeine and then the codeine. And codeine, when will you give is, in spite of giving caffeine or codeine, if the lumbar puncture headache, if it still persists, then you have to inject, right, then you have to inject low volume blood patch. Right, you have to inject a low volume blood patch to seal, right, to seal the rent means the hole, to seal the whole of that particular subarachnoid space that you have created. So that is about the basics of your lumbar puncture. Right, maximum CSF that has to be removed is 20 to 30 ml, the rate of production of CSF is 20 ml, and total amount of the CSF in the subarachnoid space is around 150 ml. And patients will have post-lumbar puncture headache, and these patients, they have advised bed rest. And if headache is increasing on straining, it is called post-lumbar puncture headache, and the drug of choice is intravenous caffeine, and you also need to give codeine. And if the headache still persists, then you have to inject low volume blood patch to seal the rent of that subarachnoid space. Now, you see this another question. All are true about the lumbar puncture except needle has to be inserted in the caudal direction. Lateral recumbent position, the bevel of the needle should face up. Legs should be straightened during measurement of the opening pressure. Needle inserted at L3, L4 space. That is, which is the incorrect statement. Now, let me discuss the procedure, right? And then we will come back to this question. The procedure is that you have to make the individual to lie in the lateral position with knees and head being flexed, or in the sitting position with the head being flexed. Okay, so please remember, so the position of the patient for lumbar puncture, it is very important, and this is how the individual has to be made to lie, right? And he is asked to lie on the edge of the bed and asked to roll up into a ball. So he is asked to lie at the edge of the bed and asked to roll up into a ball. Okay, and the neck is gently anti-flexed and thighs pulled up towards the abdomen, right? Pulled up towards the abdomen. Shoulders and pelvis should be vertically aligned, right? Shoulders and as well as pelvis, both of them, they have to be vertically aligned. And the spinal cord, it ends, right? It ends at L1 in 94% of individuals, whereas in 6% of patients, it will terminate between L2 and as well as L3, right? It will terminate between L2 and as well as L3. So that is the reason why the lumbar puncture, it has to be done between, right? That is the reason why the lumbar puncture has to be done between L3 and as well as L4. Okay, and what will be the anatomical guideline that you will take? Anatomical guide is a line joining posterior superior iliac crest. See, this is the posterior superior iliac crest. So exactly below the posterior superior iliac crest, right? The anatomical guide is a line joining the posterior superior iliac crest or posterior superior iliac spine, right? And at that point, once you have inserted the needle, let me tell you, the needle, it has to be inserted 10 degrees cephalad direction, not in caudal direction, 10 degrees cephalad direction with the bevel of the needle facing upwards. Right, with the bevel of the needle facing upwards. Okay, this way the cutting edge of the needle is parallel to the fibers of the dura mater. What is the purpose of keeping the bevel facing upwards? This way the cutting edge of the needle is parallel to the fibers of the dura mater. And if you take this particular needle, the needle used is typically, right, the needle used typically is 20 or 22 gauge needle and should be inserted in midline with bevel facing pointed upwards, right? The bevel has to be pointing upwards. Okay, so now what is the advantage of this? The advantage is that this will minimize the injury to the fibers as the dura is penetrated. Okay, so why? Right, why the bevel has to be faced upwards is, that is to minimize the injury right, to minimize the injury to the fibers. Okay, now once you have entered into the subarachnoid space, a pop sound on entry will be there, right? So you will have a little sense of ease, right? You will not be able to appreciate this pop sound, but you have that sense of ease once you have entered into, right? Once you have entered into the subarachnoid space. Okay, and once you have entered into, once the needle has entered into the subarachnoid space, the CSF is allowed to drip into the testing tubes, right? The drip is allowed into the testing tubes. Okay, now to record the pressure, a manometer, so if you want to measure the CSF pressure, then what is that you need to do? Right, to record the pressure, a manometer with a three-way stopcock is attached to the lumbar puncture needle, right? And the assistant can help the patient extending his legs and gently returning neck back to the neutral position. And whenever you are measuring the pressure, the legs are gently brought to the normal position. Actually, he was in which position? He was like in a flexed position where the knees are brought to the abdomen. So the assistant can help the patient extend his knees and gently return the neck back to the neutral position. And the reading on manometer can be checked and variation of the pressure with respiration is being noted. So that is what is the procedure of the lumbar puncture. So if you see this question now, needle is inserted in a caudal position is a wrong statement. Needle, it is inserted in the cephalad direction. Lateral recumbent position and bevel of the needle being faced upwards is a true statement. Legs should be straightened during the measurement of the opening pressure is a true statement. Needle inserted in L3 and L4 is a true statement. And needle inserted in the caudal direction, right, that is a wrong statement. Now, after having discussed about this, so now let me discuss the CSF analysis first in a normal individual or normal CSF, how it will be, and what will be the CSF in the pathological conditions we will discuss. So the question is, which of the following substance is less in CSF when compared to plasma? All except. That means the question is like, all of these following substances, they are less in the CSF when compared to plasma, except one substance, it is more in the CSF than compared to plasma. That is a question. The options are glucose, chloride, protein and calcium. Now let me discuss the values and then come back to this question. So if you take the serum glucose value or plasma glucose value, fasting blood sugar will be less than 100 milligrams per deciliter, whereas the CSF value will be 2/3 of the blood value, right? 2/3 of the blood value. And if you take the protein value is around 6 to 8 milligrams per deciliter in the blood, whereas in CSF it is, it is 6 to 8 grams per deciliter in the blood, whereas in the CSF it is around 15 to 45 milligrams percentage, that is in the CSF. Then you take the calcium. The blood value of the calcium is around 9 to 11 milligrams percentage, whereas in the CSF it is just only 2 to 3 milligrams percentage. And if you take the chloride value in the blood or in the serum, it will be around 96 to 106 milliequivalents per liter, right? 96 to 106 milliequivalents per liter, whereas in the CSF it is more than that of the blood value. And how much will be that? That is around 120 milliequivalents per liter. That is what will be the CSF value, whereas in the blood it is around 96 to 106 milliequivalents per liter. So which of the following substance is more in the CSF than compared to that of the blood? That will be the chloride. So chloride will be more in the CSF than compared to that of blood. So if you see this question now, less in CSF when compared to plasma is all except. What is the answer? The answer is chloride, right? The answer is chloride. Now you see the next question. CSF glucose level is, right, when you compare that with the plasma, half the plasma glucose, 2/3 the plasma glucose, 1/3 of the plasma glucose, same as the plasma glucose. The CSF glucose level is 2/3 of the plasma glucose. Now let me discuss this. Already I have discussed, right? Now let me discuss few more values of the normal person. If you take the color and appearance of the CSF in a normal person, the color and appearance, it will be absolutely clear, right? It is like water. And what will be the normal CSF pressure? That will be around 90 to 180 millimeters of water, right? 90 to 180 millimeters of water in lateral recumbent position. And the glucose, it will be around 40 to 70, right? It will be around 40 to 70 milligrams per deciliter, right? And how much will be the fasting blood glucose in the serum? It is less than 100, and it is exactly 2/3 of it. That will be around 40 to 70. And the protein value will be around 15 to 45, right? 15 to 45 milligrams per deciliter. And if you take the LDH value, that is lactate dehydrogenase value, that will be less than 20 units per liter, right? That will be less than 20 units per liter. That will be the LDH value, or approximately 10% of the serum levels. That will be the lactate dehydrogenase value. Then if you take the pH, right? So the pH, it is around 7.28 to 7.32. That is a normal pH of the CSF. And the chloride already we have discussed, that is around 120, or it can be even up to 130 milliequivalents per liter. And if you take the CSF osmolarity, that will be around 280 to 300 milliosmoles per kg. Right, 280 to 300 milliosmoles per kg. And the total cell count, if you see, most of the time the CSF is free of cells, or if at all, you can have the white blood cells, and that will be less than 5 cells per cubic millimeter, or less than 5 cells per ml. Out of this, 40 to 80% will be lymphocytes, monocytes will be around 15%, polymorphs will be 0 to 6%. And what will be the specific gravity of this CSF? The specific gravity of the CSF is 1.006 to 1.008. That will be the specific gravity of the CSF. Okay. Now, after having discussed about the normal CSF, now let me discuss this important question. Which of the following organism does not require latex agglutination test? The options are Streptococcus pneumoniae, Neisseria, E. coli, and then the Staphylococci. The answer here is the Staphylococci does not require the latex agglutination test. What is latex agglutination test? I will discuss. But before that, let me tell you, or let me discuss what will be the CSF picture in the bacterial meningitis. The pressure in the CSF will be increased. That will be more than 180 millimeters of water. And what about the glucose? The glucose, it will be utilized, right? The glucose will be utilized. Okay. And once the glucose is being utilized, how much it will be? It will be less than, so basically the glucose is reduced. If you can just write this, that will be more than enough, right? And that will be means less than 40 milligrams per deciliter. And what will happen to the proteins? The proteins are elevated. That will be more than 45 milligrams per deciliter. And what will happen to the total cell count? Even the total cell count is increased, right? Even the total cell count is increased. And what will happen to the pH? See, the pH of the individual, it becomes acidic in nature, right? The pH of the individual, it will be acidic in nature. So please remember, that's an important point. Okay, then what happens to the LDH value, that is lactate dehydrogenase value, that will be elevated. And what happens to the osmolality? That also gets elevated. Why? Because the cells increase, the inflammatory substances increase, and that is the reason why the osmolality and as well as the specific gravity, both of them, they get increased. And chloride, they remain more or less the normal value, right? Chloride, more or less, they remain normal value. Now, coming to the latex agglutination test. What is the importance of this latex agglutination test? See, the latex agglutination test is a laboratory method to check for certain antibodies or antigens, right? That is to check certain antibodies or the antigens, right? And this latex agglutination test will check the antibodies and as well as antigens in a variety of body fluids. Right, we'll check in a variety of the body fluids, right? So, where all this latex agglutination test will check, it will check within the saliva, right? It will check the antibodies and antigens within the saliva. Then in the urine, cerebrospinal fluid, and as well as in the blood. That is what is the importance of the latex agglutination test. And this latex agglutination test may be positive in patients with meningitis due to Streptococcus pneumoniae. Right, the latex agglutination test may be positive in patients with meningitis due to Streptococcus pneumoniae, or secondary to Neisseria meningitidis. Secondary to Haemophilus influenza. Right, and secondary to Escherichia coli. And then group B, Streptococcus. Right, group B, Streptococcus. So in all these scenarios, the latex agglutination test may be positive. Now, you see this question now. So, which of the following organism does not require latex agglutination test? That will be Staphylococci. Whereas Streptococcus pneumonia, Neisseria and as well as E. coli, in all of them, the latex agglutination test may be positive. Then, we have one more test called Limulus lysate test. Limulus lysate test, it is positive in cases of gram-negative meningitis. Right, it is positive in gram-negative meningitis. And another important test is the PCR, that is polymerase chain reaction, that will detect the bacterial DNA. Right, that will detect the bacterial DNA. So, you take the Limulus lysate test now. Limulus lysate test in CSF is positive in all of the following conditions except E. coli, Neisseria, Klebsiella, Streptococci. Now, Limulus lysate test will detect the gram-negative organisms. Right, so these are all the gram-negative organisms, wherein the Limulus lysate test will be positive. Whereas, in case of Streptococci being a gram-positive organism, Streptococci, it is a gram-positive organism. So, in case of gram-positive organisms, the Limulus lysate test will be of no use. Limulus lysate test will detect only the gram-negative organisms. Okay, so that is about the CSF picture in the bacterial meningitis. Now, you see another question. Which of the following is not seen in the tubercular meningitis? The evidence of old pulmonary lesion or miliary pattern is found on the chest X-ray. Second option, culture of CSF is diagnostic in majority of the cases and remains the gold standard. Third option, it is seen most often in young children but also develops in adults. Cerebrospinal fluid reveals a low leukocyte count. Okay. Which of the following is not seen in tubercular meningitis? Now what I will do, let me discuss the CSF picture in all the forms of meningitis and then we will come back to this question. So, you take this acute bacterial meningitis, tubercular meningitis, viral, Guillain-Barré syndrome and then fungal meningitis. What will be the CSF picture? We will discuss one by one. Okay. So, you take the CSF pressure, it will be increased in bacterial meningitis and it will be increased in all the forms of meningitis, but it will be normal in Guillain-Barré syndrome. And you take the CSF color. The CSF color, it will be clear in case of the bacterial meningitis and the CSF color is also clear even in case of the viral meningitis and CSF color is also clear in case of the fungal meningitis. And in Guillain-Barré syndrome, it is a normal CSF color. But in case of tubercular meningitis, it will be turbid in appearance. Then coming to the cells. In a normal individual, what did I tell you? It is around less than 5 cells, out of which it is mainly the lymphocytes which are present. Almost like 80% will be the lymphocytes out of those 5 cells. But in acute bacterial meningitis, there will be neutrophilic predominance. Right? N stands for neutrophil. There will be neutrophilic predominance. Whereas in tubercular meningitis, it will be lymphocytic predominance and the lymphocytes will be more than 100 cells per cubic millimeter. And even in viral meningitis, it is the lymphocytic meningitis and in Guillain-Barré syndrome, the CSF is acellular, right? You don't have any pleocytosis at all in the Guillain-Barré syndrome. And in fungal meningitis also, right? In fungal meningitis also, it is the lymphocytic predominance. And if you take the glucose, right? The glucose in case of acute bacterial meningitis, the glucose is utilized, so the glucose is reduced. Even in case of tubercular meningitis, the bacilli will utilize the glucose, so the glucose is reduced. And in viral meningitis, the CSF will be normal, the glucose will be normal, and Guillain-Barré syndrome, the glucose will be normal. Whereas in fungal meningitis, right, the glucose will be utilized and the glucose will be low. Whereas proteins, if you see, the proteins, they are elevated. Right, the proteins are elevated in all the forms because proteins, they are involved in only in fungal meningitis, the proteins may be normal or they are elevated. See, proteins, they form the part of the immunoglobulins. So whenever there is inflammatory reaction, the immunoglobulins will be increased. So it is an inflammatory reaction which is happening within the meninges by these organisms. So once there is inflammatory reaction, the immunoglobulins will be elevated, right, because they try to come and attack the organism, and your immunoglobulins are nothing but the proteins. So proteins will be elevated in all the forms of meningitis, and particularly if you take Guillain-Barré syndrome, we call this as albuminocytological dissociation. Now what do you mean by this word? Right, what do you mean by this word albuminocytological dissociation? Albuminocytological dissociation means the albumin levels will be very high then compared to that of cells. Right, then compared to that of cells, the albumin levels will be very high, and that is called as the albuminocytological dissociation. Now, after having discussed about the CSF picture in various forms of meningitis, now let me discuss about the tubercular meningitis. See, tubercular meningitis is seen most often in young children, but also develops in adults as well. Right, most commonly seen in most commonly seen in the young children, because in young children the immunity is less, so the tuberculous organism can easily infect the child. But it also develops in adults, especially those infected with HIV. Right, it is also seen in adults, especially those infected with HIV. That means immunocompromised state, the tuberculosis can cause the tuberculous meningitis. Now, this tuberculous meningitis results from the hematogenous spread of primary or post-primary pulmonary tuberculosis. So, this tuberculous meningitis, it results from hematogenous spread of the tuberculous organism. Right, it results from the hematogenous spread of the tuberculous organism from the lungs to the brain, and the disease often presents subtly as the headache and slight mental changes after a prodrome of weeks of low-grade fever. So that means these individuals, they'll have low-grade fever initially, right, that will be there for weeks, right, that will be there for weeks. Followed by that, there will be development of the tuberculous meningitis, and due to which they'll have the development of headache and as well as the mental changes. Okay, so these will be the manifestations in patients with the tubercular meningitis. And in patients with tubercular meningitis, the basal meningitis is also very common. Now, what is this basal meningitis? See, the characteristic pathological feature of tuberculous meningitis is predominant involvement of the basal meninges while sparing the convexities of the brain, right? So, the basal meninges, they are inflamed more commonly than compared to that of convexities of the brain. Right, then compared to that of the convexities of the brain, and the brunt of pathological process falls on the basal meninges, where a thick gelatinous exudate will accumulate here. So at the basal meninges, there will be accumulation of thick gelatinous exudates. They get accumulated at the base of the meninges, okay, and that will result in the development of the basal meningitis. And particularly if you see the clinical features of the tubercular meningitis, and I said you in children it is more common. So you know, the child, they present with history of few weeks of history of few weeks of head banging. right, history of few weeks of the head banging, and this particular child is irritable and drowsy. Right, this particular child is irritable and drowsy, and they have low grade fever as well, and there will be gradually developing, right, there will be gradually developing neurodeficit. And this tubercular meningitis, these patients, they also develop endarthritis. Right, they also develop endarthritis. Okay, and due to which, right, due to development of endarthritis, they will have the seizures. Right, they will have the focal deficit. Right, and they can have the nuchal rigidity. Right, they will have nuchal rigidity. That is because of the tuberculous endarthritis. Okay, so these will be the clinical features of the tubercular meningitis. And regarding the CSF examination, already we have discussed about the CSF examination of tubercular meningitis. But let me show you one image, right? So CSF is collected in the test tube, right? What is the diagnosis? You know, like what is this being formed? This is nothing but the cobweb coagulum. Right, and what will be there in this cobweb coagulum? That is proteins. And in which scenario you will have this cobweb coagulum formation? That is in patients with tubercular meningitis, you have this cobweb coagulum. Then if you take the imaging studies in tubercular meningitis, the imaging studies may show the hydrocephalus. So what will be the features of hydrocephalus in CT or MRI? In hydrocephalus, there will be dilated ventricles. Right, there will be dilated ventricles. That is what you will observe in hydrocephalus. And there will be abnormal enhancement of the basal cisterns. Right, abnormal enhancement of the basal cisterns. That is what is the imaging studies in patients with the tubercular meningitis. Now, if you take the brain gross image in a patient with tubercular meningitis, you will have this lesion and you need to identify the lesion. And what is this particular lesion? This particular lesion, it is called as, right, this is called as the rich focus. Right, this is called as the rich focus. And what is this particular rich focus? Rich focus is a tuberculous granuloma. Right, it is a tuberculous granuloma occurring within the cortex or meninges of the brain. Right, within the cortex or meninges of the brain. And when this rich focus, once it ruptures, right, once it ruptures into the subarachnoid space, right, once it ruptures into the subarachnoid space, that will cause the tuberculous meningitis. Right, that will cause the tuberculous meningitis. That is what you will observe in the rich focus. And the rich focus is named for a pathologist, that is Arnold Rice Rich. Right, it is named after a pathologist, that is Arnold Rice Rich. Right, he is a pathologist at Johns Hopkins Hospital, and who along with colleagues Howard McCordock first described the postmortem findings of caseous foci within the cerebral cortex or meninges. Okay, so what is this? This is actually a caseous foci, right? And he is the one, right? So Arnold Rice Rich, right? He is the one who has first described this particular postmortem findings of the caseous foci within the cerebral cortex or meninges. Okay, and that can predispose for the development of meningitis. And one more important sign that you have to know in case of tubercular meningitis is, see, whenever these patient develops the hydrocephalus, the sutures, the skull sutures, you know, they may slightly get separated, and that will appear by a sign called as the crackpot sign. Okay, crackpot sign. And this is also called Massivan sign, and you know, because of the sutural diathesis, right, because of increase in the space between the sutures, right, because of increase in the space between the sutures, you know what is that you can observe? Superficial veins are visible. Right, superficial veins are visible. That is called as the Massivan sign or the crackpot sign. Okay, so this Massivan sign, it is the characteristic feature of particularly tubercular meningitis, but it can be seen in other forms of meningitis where you have the complication of the hydrocephalus. Okay, next. Now then followed by that, what will be the investigation of choice? The investigation of choice is the polymerase chain reaction of the CSF sample or the gene expert, right? So you need to do what is called as the CDNAT, that is CBNAT, cartridge based nucleic acid amplification test. So this CBNAT will detect the tubercular DNA, and within 2 hours you will be able to make out the result of the tuberculous DNA being present or absent. And finally, the treatment is that you need to give the anti-tubercular drugs, and these anti-tubercular drugs are given for nearly around 6 to 9 months, right? 6 to 9 months. So that will be the treatment for tubercular meningitis. And what is the advantage of steroids in case of tubercular meningitis? See, you need to give a short course of steroids, right? You need to give a short course of steroids, and the purpose of giving the steroids is mainly to reduce the cerebral edema. Right, that is mainly to reduce the cerebral edema. Okay, and the another advantage of this particular steroids is that they increase anti-tubercular drug penetration into the CSF. Right, they increase ATT penetration into the cerebrospinal fluid. That is what is the advantage of giving the steroids, right? What the steroids do? They increase the ATT penetration into the CSF. Okay. Which of the following is not seen in case of the tubercular meningitis? That is, the cerebrospinal fluid showing low leukocyte count will not be there. There will be lymphocytic predominant in this individual. Right, and there can be evidence of old pulmonary lesions or miliary pattern on the chest x-ray, and by hematogenous spread the individual will develop tubercular meningitis, and the culture of CSF is diagnostic in majority of the cases, and it is seen most often in young children but also develops in adults. In young children, why? Because the immunity of the individual is less. Now you see another important clinical scenario. Yes. So, a patient presents with headache and nuchal rigidity, lumbar puncture was performed and CSF shows normal protein and normal glucose with clear CSF. Microscopic examination of the CSF showed the 50 lymphocytes per cubic millimeter with lymphocytic pleocytosis. What is the diagnosis in this clinical scenario? See, already we have discussed the CSF picture. What did I tell you? Normal protein, clear CSF, normal glucose, but lymphocytic predominant. That can be there in case of viral meningitis. Whereas, you take in other forms of meningitis. In other forms of meningitis, you don't have the normal glucose. Glucose is reduced in the other options whichever has been given to you. In bacterial meningitis, neoplastic meningitis and fungal meningitis, the glucose will be reduced. Okay, next. Now, let me discuss about this viral meningitis. So, if you take the viral meningitis, like you need to know, see, yes, what will be the typical profile, right? What will be the typical profile in viral meningitis of, the CSF profile. Already we have discussed. One, lymphocytic predominance will be there, right? The protein, the CSF protein, it will be normal protein or maybe increased. It can be normal also, but the glucose will be normal, right? The glucose will be normal and there will be normal or mildly elevated CSF pressure, right? Normal or mildly elevated CSF pressure. That is what you will observe in case of the viral meningitis. And if you see the characteristic features of the viral meningitis, the most common virus which is causing the viral meningitis is the enterovirus. And what is the most common cause of viral encephalitis? That is Japanese bee encephalitis in India. Right, Japanese bee encephalitis in India. And globally, it is herpes simplex virus 1. Right, herpes simplex virus 1, it is the most common virus globally, right? And this HSV1, it has the predilection of the temporal lobe, right? It has a predilection for the temporal lobe, okay? And there is also, this can also cause the damage or the destruction of the hippocampus. And because of this hippocampal involvement, these individuals, they may develop dementia because the hippocampus is a seat of memory. And lumbar puncture, it will be bloody CSF, right? Bloody CSF in herpes simplex virus 1, right? And this bloody CSF, what will be the differential diagnosis? The differential diagnosis for the bloody CSF will be subarachnoid hemorrhage, then traumatic lumbar puncture, right? Subarachnoid hemorrhage and traumatic lumbar puncture, you have the presence of the bloody CSF. And in traumatic lumbar puncture, what will be the source of the blood? The source is epidural plexus. Right, the source is the epidural plexus. Now, what will be the investigation of choice? The investigation of choice is polymerase chain reaction of HSV1 on the CSF, right? PCR of HSV1 on CSF. And EEG, when you do in patients with the HSV1, there will be what is called PLED, right? So, what do you understand by this word? What do you understand by this word PLED? That is periodic lateralized epileptiform discharge. Right, periodic lateralized epileptiform discharge. Okay, so this will be the periodic sharp, this will be the EEG in patients with HSV1. And you have periodic sharp wave complexes in case of prion disease. Right, so in case of prion disease, that is Creutzfeldt-Jakob disease, you have periodic sharp wave complexes, right? And how will you treat this viral meningitis? See, the drug of choice in case of viral meningitis will be empirical acyclovir. Right, it will be empirical acyclovir. So that is about your viral meningitis. Right, now after having discussed about the viral meningitis, you see one more clinical scenario. 32-year-old HIV positive female presented with headache and nuchal stiffness. And lumbar puncture, the clear CSF was obtained with leukocytosis of more than 100 cells per cubic millimeter. India ink stain was positive. What is the most likely diagnosis? See, the individual is HIV positive, that means immunocompromised. And headache is there, nuchal rigidity is there. So, suggestive of meningitis. And lumbar puncture is showing the leukocytosis of like more than 100 cells per cubic millimeter. And India ink is positive. So what do you think is the most common, most probable diagnosis? It should be the fungal meningitis. And the fungal meningitis which is commonly seen in HIV infected individual will be the Cryptococcus meningitis. So if you take the fungal meningitis, the most common organism responsible for fungal meningitis will be Cryptococcal meningitis. Right, cryptococcal meningitis. And this cryptococcal meningitis, it is common in HIV infected individual. And what is the portal of entry in case of the fungal meningitis? The portal of entry, it is from lungs. Right, that is from lungs. It goes into the brain. And what will be the drug of choice for fungal meningitis? The drug of choice will be amphotericin B. Right, drug of choice will be amphotericin B. And another important drug will be 5-fluorocytosine. That will be the treatment for the fungal meningitis. Right, and let me discuss that in little detail. So the drug of choice is the amphotericin B. And you have to give this amphotericin B through the intravenous route. And this amphotericin B this has to be given at a dosage of 0.7 milligram per kg daily. Right, this has to be given at a dosage of 0.7 milligram per kg daily. Or you need to give liposomal amphotericin. Right, you need to give liposomal amphotericin. And the dosage of this liposomal amphotericin is 4 to 6 milligrams per kg daily. And this amphotericin should be given along with flucytosine. Right, should be given along with flucytosine. And the dosage of flucytosine is 25 milligrams per kg. Right, the dosage is 25 milligrams per kg. And this amphotericin B plus the flucytosine should be given for at least 2 weeks. Right, should be given for at least 2 weeks until the CSF culture turns negative. And amphotericin B plus flucytosine should be followed by giving the fluconazole. And this fluconazole should be given 400 milligrams, right, should be given 400 milligrams per day orally for 8 weeks. Right, for 8 weeks. And then followed by that, you need to give fluconazole 200 milligrams per day. Right, 200 milligrams per day until the CD4 plus T lymphocyte count is increased to more than 600. until it is increased to more than 200, you have to give the fluconazole of a dosage of 200 milligrams per day, right? So this is the treatment for your fungal meningitis. Now, we will discuss some questions now. So you see this question, the following conditions are associated with raised lymphocytes except viral meningitis or encephalitis, tubercular meningitis, partially treated bacterial meningitis, Klebsiella infection, Behçet's disease, right? That means the question is like, in which of the following conditions you don't have increase in the lymphocytes. Now, Klebsiella infection, it is a bacterial infection. So, in bacterial infection, you have increase in the neutrophils, right, but not increase in the lymphocytes. But whereas you take in all other forms of meningitis, it is mainly lymphocytic predominant, right? It is mainly lymphocytic predominant. Okay. Now, so these are all the conditions which are associated with the lymphocytic predominant: viral meningitis or encephalitis, tubercular meningitis, partially treated bacterial meningitis, Lyme disease, then Behçet's, SLE, lymphoma, leukemia. So all these conditions, they are associated with raised lymphocytes. Now, one more question. The following conditions are associated with raised protein levels except, right? Following conditions are associated with raised protein levels except Guillain-Barré syndrome, tuberculosis, spinal block, the cryptococcal infection, right? That means in which of the following conditions they don't have raised protein levels. So you take in case of the cryptococcal infection, which is a fungal infection, the protein levels, they are either normal or increased. But sometimes it may be normal also. But if you take in all the first three conditions, definitely there will be increased proteins. Definitely there will be increased proteins in Guillain-Barré, tuberculosis, and as well as the spinal block. So the conditions which are associated with raised proteins include Guillain-Barré syndrome, tuberculosis, viral and bacterial meningitis. Right? Then followed by that, the Freund syndrome, that is spinal block. Right? You have raised proteins. Okay. And what is this Freund? Okay. Spinal block is nothing but your Freund syndrome. Okay. And in patients with viral encephalitis. So these are all the conditions where you have the raised proteins, and in fungal meningitis and viral meningitis, the proteins may be normal or they may be increased. Okay, and you see one scenario. True about CSF finding in pyogenic meningitis is proteins increased, sugars decreased, proteins decreased, sugar increased, chloride increased, protein decreased, decreased protein and decreased chloride. So let me tell you, pyogenic meningitis, it is nothing but the bacterial meningitis. So in bacterial meningitis, you have increase in the proteins and decrease in the sugar. That is what you will observe in bacterial meningitis. Next, you see another question. The CSF finding in tubercular meningitis are all of the following except raised protein, low sugar, low chloride, high RBC count. In tubercular meningitis, you don't have the high RBC count. RBC in the CSF is seen in subarachnoid hemorrhage or traumatic lumbar puncture. There you have the presence of high RBC within the CSF. Whereas in tubercular meningitis, there is raised protein, low sugar and as well as the low chloride as well. Right? And next question. CSF picture in viral meningitis is all except lymphocytic pleocytosis, WBC count more than 1500 cells per ml, sugar is normal, sugar is very low, proteins are elevated. Let me tell you, in viral meningitis, sugar is very low is a wrong statement. The viral meningitis, the organisms, they don't utilize the glucose. Sugar will be normal. Now, let me tell you, sugar being very low, it is an incorrect statement. Lymphocytic pleocytosis will be there, WBC will be elevated, sugar is normal, and proteins again, it is either normal or elevated in patients with the viral meningitis. Okay, right. So, this will be the CSF picture in viral meningitis. And you see another question. acute pyogenic meningitis, what is the false statement? Purulent exudates within the leptomeninges, CSF cloudy with polymorphonuclear neutrophils spreads to the ventricles, causes ventricular enlargement. Most common organism is staphylococci. So, purulent exudate within the leptomeninges is a true statement. CSF will be cloudy because of increase in polymorphonuclear leukocytes. Spreads to the ventricles is also a correct statement. Causes ventricular enlargement is also a correct statement. But most common organism causing staphylococci is a wrong statement. Most common organism pyogenic meningitis will be Streptococci. Right? So, the answer is E. Right? The answer is E. Now after having discussed about the false statement of acute pyogenic meningitis, you see one more question. Right. In acute pyogenic meningitis, all are true except purulent exudate with leptomeningitis, CSF cloudy with lymphocytes spread to the ventricles causes ventricular enlargement. So, CSF cloudy with lymphocytes, that is a wrong statement in case of pyogenic meningitis. Okay. Now, after having discussed about the various CSF pictures and various forms of meningitis, let me discuss the complications of meningitis. Neurological complications of meningitis include all of the following except seizures, increased intracranial pressure, cerebral hamartoma, subdural effusion. Now, if you see the common complications of meningitis, these individuals with meningitis, that too chronic meningitis, they develop syndrome of inappropriate antidiuretic hormone. There is excessive ADH which is being produced, and due to which there will be dilutional hyponatremia in patients with meningitis. Hyponatremia is another important complication. And other complications, in the beginning itself I have discussed, there will be development of hydrocephalus, and that is due to block in the CSF flow, and wherein the absorption of the CSF across the subarachnoid space does not occur. And these individuals will also develop stroke, that is due to raised intracranial pressure. And because of raised intracranial pressure, there will be also cranial nerve palsies. Right? And what is that cranial nerve palsy? There can be third cranial nerve palsy, due to which there will be pupillary dilatation, and there can be sixth cranial nerve palsy. And because now you see the inflammation from meninges will spread to the brain parenchyma, and that we call it as meningoencephalitis. And once there is development of meningoencephalitis, there can be development of seizures as well. Right? There can be development of seizures as well. Okay, and these patients, they develop encephalitis, that is meningoencephalitis. So, as a part of the encephalitis, the individual will have CNS manifestations like hallucination, agitation, personality changes, psychotic state, focal signs. These are the features of the encephalitis, right? And in tuberculosis, there can be development of tuberculoma, right? That is a CNS space occupying lesion, and the infection can spread to spinal cord, that is myelo, to the spinal roots, that is radiculopathy. Right? There can be development of myeloradiculopathy, so involvement of the spinal cord and as well as the spinal nerve root, and there can be also development of hypothalamic syndrome. Right? There can be also development of hypothalamic syndrome. So, these are the complications of the meningitis. And which is the complication that is not seen? Let me tell you, it is your cerebral hamartoma. What is cerebral hamartoma? It is a tumor within the brain that will not be seen in patients with the meningitis, but there can be development of seizures, there can be raised intracranial pressure, and there can be subdural effusion as well. Now, another question on the complication. All are complications of tubercular meningitis except hydrocephalus, yes, it will be there. Infarction, yes, it will be there because of tubercular endarteritis. Obliterative endarteritis, yes, it will be there. But sinovenous thrombosis, that is not seen in case of the tubercular meningitis. Right? Sinovenous thrombosis will not be seen in patients with the tubercular meningitis. Right? Please remember, it's an important question. Next, all of the following is incriminated in causing non-infectious chronic meningitis except ibuprofen, acyclovir, beta-lactam antibiotics, then phenobarbital. Now, you need to know, right, what are the drugs, right? It is not the question with except, which of the following drug is incriminated in causing non-infectious chronic meningitis. You need to know that we have a clinical entity called drug causing meningitis. And why is that due to? That is due to drug hypersensitivity reactions. Right, so due to drug hypersensitivity reaction, there is development of the chronic meningitis. And here, in case of the drug hypersensitivity reaction, the cerebrospinal fluid, it shows mononuclear cells or eosinophils. Right, it will show mononuclear cells or eosinophils. And even complete blood picture will show the presence of eosinophilia. Right, will show the presence of eosinophilia. Now, you need to know what are the drugs which are incriminated in the development of the non-infectious meningitis. One is your NSAIDs, that is ibuprofen. Then antibiotics like sulfonamides will cause non-infectious meningitis. Then we have penicillin, then beta-lactam group of antibiotics, and first-line anti-tubercular drug, that is isoniazid, then quinolone group of antibiotic, that is ciprofloxacin. Then we have an anti-epileptic drug, that is lamotrigine, right, anti-epileptic drug, that is lamotrigine, and then intravenous immunoglobulins. So these are the drugs which are incriminated in causing the meningitis, right? Then we have one more important type of meningitis called as the molarate meningitis, right, which is also called recurrent meningitis. So molarate meningitis, it is an aseptic meningitis. Right, it is an aseptic meningitis, and this is also called benign recurrent lymphocytic meningitis. Right, benign recurrent lymphocytic meningitis. And what does the CSF show in case of the molarate meningitis is, the CSF shows large endothelial cells. And polymorphonuclear leukocytes. That is what you will have in the CSF. And the most, so this is what is your the molarate meningitis or the recurrent meningitis, right? Next, now after having discussed about the various forms of meningitis, so you have one question on the treatment of the bacterial meningitis. A 45-year-old female is diagnosed as a case of pneumococcal meningitis. Blood sample was sent for the culture sensitivity. Meantime, the best drug to start as an empirical treatment is penicillin G, doxycycline, streptomycin, vancomycin plus ceftriaxone. Let me tell you, the treatment in case of the bacterial meningitis as an empirical treatment is, you need to start vancomycin plus ceftriaxone. So this ceftriaxone you need to give 2 grams intravenously because it has to cross the blood-brain barrier. 1 gram will not cross the blood-brain barrier. You need to give 2 grams in order to ensure that the ceftriaxone has to cross the blood-brain barrier. Okay. So actually you have to start with vancomycin and ceftriaxone, and once the culture and sensitivity appears, then you need to give that particular antibiotic according to the culture and sensitivity. Right, it will be the ceftriaxone. And what will be the duration of this antibiotic that you need to give? you need to give for nearly around 1 week. So if you take the antibiotics, in case of immunocompetent children of more than 3 months or less than 55 years, the antibiotic that you need to give is cefotaxime or ceftriaxone or cefepime plus vancomycin. And in individuals aged more than 55 years, in them you need to give ampicillin plus cefotaxime, or the other combination is ceftriaxone or cefepime plus vancomycin. Whereas in case of the hospitally acquired meningitis, post-traumatic or post-neurosurgery meningitis, in them you need to give ampicillin plus ceftazidime or meropenem plus vancomycin has to be given. So this is about the antibiotics used in empirical therapy of bacterial meningitis and focal CNS infections. Now, after having discussed about the antibacterial drugs, you see another question. What is the drug of choice in case of Listeria meningitis? In Listeria meningitis, the drug what we give is the ampicillin, right? Very important question. Next question is, a patient presented with history of fever for 3 days with headache and photophobia. On examination, Kernig sign is positive. CSF finding report mentions lymphocyte count of 36 per ml with normal glucose level, increased protein level with increased opening pressure. Identify the etiological agent. See, the individual is having normal glucose, that means glucose is not utilized. In tuberculosis, glucose is utilized. Neisseria, bacterial meningitis, glucose is utilized. Cryptococcus, fungal meningitis, the glucose is utilized. So where is that you will have the glucose not being utilized? That is in case of the viral meningitis. So the answer is the Coxsackie virus, and in viral meningitis you have the lymphocytic predominance as well. And you take one more image based question with a clinical scenario. A 50-year-old man is on immunocompromised therapy with steroids post kidney transplant. She presents with 3 days history of fever, headache and confusion. Lumbar puncture reveals 200 polymorphonuclear leukocytes per 200 PMN cells per cubic millimeter with elevated CSF protein. India Inc. preparation slide is shown. What is the diagnosis? Pneumococcal meningitis, cryptococcal meningitis, aseptic meningitis, cerebral toxoplasmosis. See, lumbar puncture shows neutrophilic predominance and elevated CSF protein, and India Inc. stain is positive. See, when the India Inc. stain is positive, you may be under the impression that it is cryptococcal meningitis. The answer is not cryptococcal meningitis. It is your pneumococcal meningitis. Why? It's a bacterial meningitis. Why? It is polymorphonuclear predominant, neutrophilic predominant. In cryptococcal meningitis, you have lymphocytic predominant. And what is the organism which is being shown under the microscope? That is your diplococci. Right, that is your diplococci. That is what you will see in case of the pneumococcal meningitis. Whereas in case of cryptococcal meningitis, you don't have this diplococci in the India Inc. Right? In the cryptococci, what is that you will have? You will have, you see, the budding yeast cells. Right? Budding yeast cells. That is what you will see in case of the cryptococcal infection. And India Inc. will be positive. So that is about, right, that is about the story of meningitis. So you need to know the various organisms, and you need to know the clinical features, complications, and CSF picture in various forms of meningitis. You have to be very much thorough with, right? So with this, I'll wind up this very important topic, that is meningitis. Thank you very much.